Good afternoon. Thank you all for joining our webinar today. Data sharing and interoperability, adapt and innovate. We have Lloyd Biddle, the CEO, founder of Innovate Healthcare. He's our executive technical leader for Highbridge HIE. Who is Highbridge? Highbridge is one of 4 regional health information exchange in the state of Georgia, connected to GHIN, the state HIE, and the National eHealth Exchange. We offer services for the successful exchange of confidential patient clinical information and interoperability support to support optimal health outcomes in the greater community while eliminating the disparate gap of healthcare throughout Georgia and the nation. Our speakers today is Lloyd Biddle, again, the CEO and founder of Innovate Healthcare, and Josh McDonald, the technical operational lead with Innovate Healthcare. I'm going to pass it over to Lloyd Biddle.
Thank you so much, Selena. I appreciate that. And I appreciate everyone joining today. I wanted to provide some insight into what Highbridge does, and then get into some technical details about the future of HIE, as well as some of the other initiatives that are out there in the space today. So I think for Highbridge, it's key to understand that Highbridge was formed to support smaller practices and hospitals. So in the Atlanta metro area, you have your very large health systems that have various solutions that address data exchange or data exchange challenges. For Highbridge, those are not the folks that we would service. We service smaller regional hospitals, smaller practices, and our products and our solutions are designed for that niche area. We are also connected to GHIN, which means we're not storing necessarily the data. Right, we are a consumer of GHIN data. Additionally, if there are regional hospitals or smaller practices that need to exchange data, we can certainly facilitate that through GHIN, but we're not the keeper of the data. GHIN is. We are also, it's important to understand that we're agnostic when it comes to your EHR vendors. We can work with Cerner, we could work with Epic, we could work with Meditech, CPSI. For us, we're agnostic about the vendor or your vendor of choice. Our platforms can be supportive of any of those various systems. Additionally, other systems that are not necessarily in that traditional area of an EHR. So in a small hospital, your ancillary departmental systems may have some needs for data exchange. We can be supportive of that. Your ambulatory practices within the hospital that may roll up under your EHR, we're supportive of that as well. And we're not sponsored by any health system, so we're not. We're agnostic when it comes to both vendors and health systems. So we have no sponsorship or incentives to necessarily lock into a single health system. We try to be as agnostic in that area as possible. And most importantly, we fall under the Morehouse School of Medicine. So we're organized under the Morehouse School of Medicine Technology Center, which means we're sponsored by Morehouse, and we're actually on campus with Morehouse, and we have access to a number of the pieces of infrastructure that Morehouse offers for us, and it's a huge advantage for us. So let's talk about health information exchanges and what that is, what it means. And I'm going to go through kind of a brief history of HIEs and how they've evolved over the last 15 years. And then kind of talk about some of the challenges we're encountering now and how we're going to move forward in the HIE space. So from a historic standpoint, HIEs, before the HIE, they were known as RIOs, Regional Health Information Organizations. But that was in our infancy. They weren't well formed. There was no technology platforms that I'm aware of that would service those organizations, and there were just a very small number around the country. Into early 2000s, the idea of a health information exchange began to kind of formulate in the community. We then began to think about how we would exchange data between these HIEs, and out of that, in 2004, the Office of National Coordinator of Health Information Technology was formed, ONC, and out of that, this concept of a National Health Information Network was introduced. And we eventually, that National Health Information Network evolved into what eventually became NewHand, which we know today is eHealth Exchange, and what's also commonly referred to as Sequoia. And so that was kind of some history. And then in early 2009, we had the HITECH Act that was introduced during the Obama administration, and it incentivized both the EHR vendors as well as a number of other vendors that supported the HIEs to begin to adopt. And the HIEs began to collect data around the country and was formed everywhere. They were formed in primarily using three different structures. There's a public, which was essentially state HIEs. For example, Alabama, organized under Medicaid, is a state HIE. It's publicly funded. Additionally, we had privately funded HIEs. So a health system, a large health system like an Emory, that would form an HIE, and then they would form that for the benefit of their patients. And then lastly, we had, I think, the best model of the three would be the public-private partnerships, where the state and the private entity would work together to form an HIE, and that continued through the mid 2000s into 2010, and just rapidly expanding. In 2015, we had the 21st Century Cures Act, and the 21st Century Cures Act was additional funding, and they began to introduce the idea of the Trusted Exchange Framework and Common Agreement, which is TEFCA, which I'll talk about a little later. Over the years, the HIEs have evolved and changed, and there are lots of new technologies and new vendors in the market, but we've moved away from the legacy models that we used in the early 2000s and mid 2000s, and now we're into a lot of query exchange, which means we can query for patients and then they can return back their the clinical documents, which is exactly what Highbridge does with GHAN. So we query for the patient, we then query for the documents, and then present that to the provider. Moving forward, we also had this concept of the national networks, which was initially it was eHealth, and that was the only one. But then Commonwealth came in, which is a Cerner-sponsored network, as well as Care Quality, which was an Epic-sponsored network. And out of those national networks, this concept of querying for patients and getting documents returned really became an important concept. Lastly, we would say challenges. So now we're at 2023. The HITECH Act has the funding was from the HITECH Act and other initiatives over the past years has expired, and our funds are depleted. We're now moving toward developing sustainable models, sustainable financial models. How do we continue to service our providers and our patients post the Cures Act, which is really the question today. And then lastly, with ONC rolling out, with the TEFCA rolled out by ONC, and the idea of QHANs, which is a concept under TEFCA, which I'll talk about later, that's introduced some new challenges for us. And so we're moving forward with those challenges in mind, and hopefully we can address those over the coming years. So, primarily we're talking about the technical challenges, barriers and challenges, then financial and legal. So on the technical side, from a health information exchange standpoint, we're communicating with, and Selena, can you move that slide one more forward on the technical side? There we go. And so on the technical side, we're navigating inconsistent standards across the national network. So for our regional HIE, we're communicating nationally. And so with a number of vendors that are all part and participate with the eHealth Exchange. So out of that, we have a varying standards in that, and that we are navigating as we work on that national network. Additionally, we have EHR systems that are very different. Their approach to their specifications can be varying, and more issue around that would be the even within the EHR system, say a Cerner. Cerner has multiple versions of their product out there, and even within those versions, you have multiple settings that can significantly change the behavior of the software. So that just creates issues for us as we attempt to exchange data with these systems. And then we have in this area data blocking, and essentially what that means is the EHR vendor often chooses to either physically block access to the data, for example, laboratory reports. If they choose to block access to that for some reason, they can do that, and that has been a common practice, less so now. But then also, they can block technically, but also they can block financially, so to make it so expensive to get the data that you need in the format that you need it essentially becomes data blocking. And then, large geographic areas, we're working across large networks. And so the security and privacy around those large networks can be substantial to navigate. And we're often faced with challenges around how to share data across large networks. All of that means the financial challenges. There's high cost of implementation and upkeep. We have to maintain the software and the physical infrastructure and the resources to make all of this work, and that can be a financial challenge. And also in communities, for example, I live here in Montgomery, Alabama. We have a couple of health systems here, Baptist and Jackson Hospital, and in the past, certainly, in my work there, there is data blocking that happens between those facilities, data blocking concerning not wanting to share data between the two health systems, because they're fiercely competitive in this area. And if there is no financial incentive or there's no penalty for that, then they tend not to do that. And so that creates a challenge for a high bridge, because our need is to actually facilitate data sharing. And so there's a natural conflict there. And because of that conflict, the hospitals generally say, well, it's not funded. We're not sure how this would be funded, and they generally just don't do it. So that presents a challenge for us. And then, as we talked about with the Cures Act and the funding that has diminished in the Cures Act, from the Cures Act, we're now we're providing a public benefit. We're providing access to clinical data. We're providing data exchange, and a number of providers use our services and use similar services across the country. But there's a lack of a sustainable financial model as the grant funding has run out, and there's no replacement of that funding to continue to do the care and feeding of these systems into the future. And then lastly, from a legal and compliance standpoint, we deal with issues related to the emergence of TEFCA, which is the Trusted Exchange Framework and Common Agreement. TEFCA came from the ONC, and it was it was designed to address issues related to data blocking, and it was also designed to facilitate more enhanced data sharing nationally. What has happened is the number of private entities have came into to be QHINs, for example. A lot of the network providers, a number of network providers are now participating in the QHIN program and attempting to essentially facilitate that data exchange. And And that can be seen by some as somewhat competitive to what the HIEs do. And that's been done, out of from the ONC, from TEFCA, and the federal government is really pushing that. And some could see that as a threat to the HIEs. And then across borders, we have various, each state has their own specific consent laws. Georgia has a model that they use, but each state has their own. And so as we navigate across these borders, we have to keep in mind the state law with the patients that are located in the regions that we're exchanging data. We exchange data with Tennessee, for example. So we have to keep in mind that exchange, and then and be mindful of state laws in those areas that we're operating, but also the cross-border data exchange. So if we're querying Tennessee, data is coming from Tennessee. What are the consent laws in Tennessee? We have to be mindful of that. And then lastly, even more stringent is the 42 CFR Part 2, which is the substance abuse mental health data, which has a special class with the federal government. And so we have to be mindful of 42 CFR Part 2 data to ensure that we're not sharing data that's considered 42 CFR Part 2 without patient's consent. So that's another issue and challenge that we generally see in our work. So from our deployment models, there are three general deployment models with HIEs. We have, and it really is about where the data is being stored. So there are three different mechanisms. The data is stored centrally, which would be like a GHIN model. So the data is stored within GHIN. They have various source hospitals that feed them, send them demographics, send them lab results, medications, and then H&Ps, op notes, discharge summaries, what have you, and then they then service connections to them, which is exactly what GHIN does for us. And then there's a decentralized model, which is what the model that Highbridge has. In the decentralized model, we're using the networks, using our capabilities, and doing query retrieves. So in those examples, the data is physically located in GHIN. We query GHIN for data related to patients that we need to see the clinical documents for, and then they return those back to us. That's a key distinction, is that we're not a repository of the clinical data. We don't seek to have source hospitals feeding us with their clinical data and essentially replicating those EHR systems. That's generally not what this decentralized model would do. And then lastly, I would say hybrid model. And then, with the hybrid model is a combination of both centralized and decentralized, and it has some of the benefits such that it's not, there's better performance because we're not centrally locating it, but we're also decentralizing it in a way. So that's commonly referred to as the hybrid model. So just real quick, going to touch briefly on the different standards and protocols. You all have probably heard of HL7 interfaces, HL7 messages. Those are legacy protocols from the 90s and early 2000s. As we move forward, we talked about the query retrieve. That's IHE document query, which is generally in use right now through different mechanisms. And then additionally, you probably have a mailbox with your EHR system, and that's done through direct, where you can look up a provider that's within the provider directory, and you can email clinical documents to that provider. That's something that was offered as part of the direct project, and that's kind of the next iteration of the query retrieve. And then they all communicate over eHealth or either the national networks. And then moving forward, the last iteration of these changing standards and protocols will be TEFCA, and that's where we are today. So the communication methods that we use primarily is the national networks. Next slide, Selena. The national networks, HL7, and then document query and retrieve. That's the mechanisms that we generally use. So let's talk a bit about the national networks, because that's kind of future state, and that's where a lot of things are going, particularly as we evolve into TEFCA. The national networks will become super important. Next slide, Selena. So today, the networks. From the beginning, we had Sequoia in hand we talked about earlier, which is the eHealth Exchange. eHealth Exchange is primarily the VA, Indian Health and Department of Defense. It is the federal entities, but they also have other HIEs participating in eHealth, and certainly early on it was all federal entities. As we've evolved over up to today, we certainly have other participants, the other HIEs in eHealth. But if you want to say query a VA facility of the 170 plus facilities that are in the VA, you would do that through eHealth. And in fact, Highbridge is connected through eHealth. We've been connected for the past 3 months, so we're able to query across that network and do a lot of that now. Additionally, the onboarding with eHealth, I mean, it took us well over a year, maybe close to 2 years to get onboarding done. It's not easy. It's a difficult, onerous process. But once you're on it, you have access to a range of other network participants as well as other networks. And then we have Care Quality. So Care Quality was sponsored primarily by Epic early on. And early on, it was all of the Epic EHRs had access to the Care Quality Network, and it was part of the native functionality of the Epic system. So you could query any Epic customer within the Care Quality Network. That was great, and certainly answered a large or addressed a large gap in an ability to communicate and exchange data. But it left out the Cerner piece, and it left out the HIEs, and so they addressed that. They've expanded Care Quality, and it's grown to now include any system can participate in Care Quality, and then and a number of the HIEs participate in it as well. So if you're a member of that network, you can query anyone on that network for clinical data, and there's a lot of overlap. So you may have eHealth data that you're getting off of that network from a VA facility, and you maybe have Epic data you're getting off of Care Quality, and then you potentially could have other HIEs as well, all off the eHealth or Care Quality networks. And then lastly, Commonwealth, which I think Commonwealth was Cerner focused system or network. I think my general perception on Commonwealth is its use seems to be diminishing. That's my perception, and it seems to be that eHealth and Care Quality is the direction most organizations are going in. I said certainly if you're a Cerner user, you're going to use Commonwealth, but if you need to query Epic systems and you want to be able to query Cerner systems, you can do that with Care Quality or eHealth. So I would say the primary two networks out there being used would be eHealth and Care Quality. All right, so let's go on to the next line. Now, in participating in the national networks, we share data across state lines, and we discussed it a little later, a little earlier, and I want to discuss it now. The idea of sharing data across state lines and privacy and consent related to sharing that data. So there's variance in the state laws related to sharing data, and there's legal frameworks associated with that sometimes are sometimes conflict. For example, California and New York are two of the more onerous. Texas would be a third onerous states from a privacy and consent law standpoint. So it makes it a little more difficult to share data. So we have two mechanisms for sharing data. One is the opt-in model. Which is in the opt-in model, the assumption is the patient has to opt in to the HIE to have data. In Georgia, we have opt-out, which means the patient is assumed to be in the HIE, and if they don't want to participate, they have to opt out or pull their data out of the HIE. That creates a bit of a conundrum, as you have to, as a state HIE, communicating across the national networks, you need to have some awareness of that because it could impact you. And then there's an absence of national guidance about how to address these issues. Additionally, we've got technical obstacles. Participating in a network doesn't necessarily mean you have access to all of the systems that are on the network. We've encountered that here at Highbridge. Our challenge was, we had assumed that once we were onboarded with eHealth, we would be able to exchange data with any of the participants in the eHealth network. That's not been the case. We've had issues with every single data sharing effort that we've attempted. We've been able to overcome those, but it's not a plug and play deployment. There are things that need to be done each time that tend to take, in some cases, very long time. And then across all of that, the networks, it has this concept of unstructured data. And so you can see that unstructured data is like an HMP or an op note, where you have an unstructured report. And so, for example, you may have a medication in that unstructured report that may have just the description of that medication. From a system standpoint, that description of a medication really has no meaning for us. It's just text. We need what's called a coded piece of data. So you need the NDC or some other indicator of what that data is that matches and it keeps with the other coded elements that are related to that. So that makes it a little difficult when you're sharing data. If you really want to get into analytics or other ways of looking at data, it can be challenging from an unstructured data standpoint. It's an obstacle. And then often, in what we've encountered here at Highbridge, is the duplicate records. So if I'm participating in care quality and eHealth, and I'm getting data from GHIN as well, we may have you will often have more than you need, and some of it will be duplicate or overlapping, and it's very difficult to really pick the pieces of data that you actually want to see, the reports that you would actually want to see. So that can be seen as an obstacle. We can overcome it, but it is an obstacle. And then lastly, one of the more difficult challenges is the idea of patient matching. And so in an EHR, and in for example, a hospital, you have a medical record department, and the medical record department is responsible for ensuring that the medical record number assigned to the patient stays with that patient for the life. And so you have a longitudinal view of the health record, and you're relatively assured that, assuming there's no duplicate medical record numbers, you're relatively confident that is the patient. In an HIE setting, that is not the case. Patient matching is done through logic and algorithms. There's no physical medical record department. It is the logic, the infrastructure that does the matching. And that's done through algorithms, through code, through technology. And that can be challenging, particularly as you're matching across state exchanges. For example, Texas would have different patient matching algorithm, we call it tuning, than say Atlanta, because Texas has a large Hispanic population. And so around El Paso and other areas, they have different mechanisms. They have different tuning that you would have in Atlanta. So that makes it very difficult on a national level to communicate across states. And then duplications. If you have some data inconsistencies, for example, a lab report, you're getting a lab report and there's maybe an addendum to that lab report, and you query the national networks, you're getting that report, you may get the addendum, thinking you have the final, and there's some inconsistencies there. Not it's rare, but it does exist. And then lastly, I would say a lack of a national standard for how to identify a patient. So there's no national identifier or any mechanism such that we can, across state lines, identify patients. And so that makes it challenging. For example, in the VA, every patient in the VA is uniquely matched, right? You do have assurances from the Social Security number that every patient is the patient that you think it is. Outside of the VA, that is rarely the case. And so that presents some challenges there. All right, so that is an overview of the HIE landscape, some ideas about what a Highbridge does, some of our challenges we're trying to overcome, and how we see the HIE moving forward into the future. So with that, I turn it back over to Selena.
I just want to thank you, Lloyd, so much for that valuable information. As we continue our conversation, as we all know, this is important, very important, and it's not going anywhere. And technology is going to continue to evolve and transform healthcare and change the way services are delivered. So as we go into our fireside chat with you experts, with Josh and Lloyd Biddle with Innovar, I have a few questions that came from some of our attendees, and I would like to present those to you. Last week, the HHS proposed a new rule that's going to establish disincentives for healthcare providers that have committed information blocking. How can participating in an HIE avoid these consequences?
Well, I think from a data, let's first define what data blocking is, or what we believe the data blocking is, and how that's defined in the regulation.
Okay.
So it's important to understand that if your patient requests access to their clinical data in the EHR at your practice, that access can be through an app on their phone, or it can be access through some file. That you need to have the technology in place such that you can be supportive of that request. And so your EHR vendor should have the appropriate mechanisms in place today, such that when that happens, when that rule is in place, and I believe probably second, third quarter, it'll be finalized next year. When that rule is in place, that you'll be able to service that request, and you'll be able to provide access to that data either through a patient portal or through an API, for an API being an app on your smartphone, or through some other file. You can provide access to the data that the patient's requesting, and it can't be data from a lab report, right? Or it could be their entire record. If you block access to that record to that request, then that is considered data blocking, and there will be disincentives for that. You can read disincentives to mean penalties for that activity.
And just to kind of piggyback on that, Lloyd, we here at Highbridge, we work with providers that are participating in the MIPS program. So as Lloyd mentioned, there can be disincentives if you guys do provide your providers do any data blocking or refuse to give a patient their records. And that it can come through your claims, negative adjustments through your claims participating in the MIPS, or if you're not a MIPS participant, of course, it will be a negative adjustment on your claims.
Yeah.
So you want to make sure you get all the information you can. We're here at Highbridge. We offer free resources. We provide these educational webinars every month. And if you have any questions, our information is at the end of this presentation.
Yeah. And the interesting point about this is they did not say penalties, right? They said disincentives. So they're not going to fine the provider, but there will be reductions in payments through either the MIPS program or through Medicare, CMS, some other mechanism. There will be disincentives. So essentially, what that means for the provider is you will be penalized for that financially, and so you should be pressuring your EHR vendors now to ensure that they have the technical infrastructure in place and also the methods in place, such that you can service these requests when they come in, and they will come in.
Thank you, Lloyd. That kind of goes into my next question. I know you mentioned APIs, and CMS has regulations where they're going to require FHIR APIs for patient access. And well, they say soon will require fire. It hasn't been finalized, of course. And they said maybe with also for prior authorization as well as payer to payer and payer to provider exchanges. So do you have any feedback on that as far as CMS regulations around the requirements of fire for API for patient access?
The not only the CMS, but also, within TEFCA, the
Okay.
general movement in the industry is toward fire-based query retrieve, which means we just simply all agree, to the format and the mechanisms for security for our APIs, and we do that in as and we call it FHIR, FHIR, right? But it's just a common agreed upon format. It's similar to HL7, right? And we just all say, we're gonna communicate in this way, and there is a standard, and that standard moving forward will be the method that we'll use to communicate from a technical standpoint, and that is the entire industry is going in that direction, and that eventually, it will replace the existing infrastructure, integration infrastructure that we have in place today. But that will certainly take time. The benefit of FHIR is it can peacefully coexist through existing interfaces, integrations you have in place, either reference labs or other integrations. Those aren't going away in the short term. But as technology evolves, as you get new releases, with your technology partners, over time, eventually it will evolve to these fire-based interfaces. And I think the CMS statement is just reflective of that reality.
Okay. And I know you mentioned TEFCA. Do you want to kind of touch on that? What is TEFCA? How does it work? What is the goal? How it's going to affect HIEs or affect organizations?
So, let's talk about TEFCA. And so TEFCA is an acronym. It stands for the Trusted Exchange Framework and Common Agreement. And, TEFCA helps us to address the idea of sharing data across a national, using a national framework. It's just simply saying we all agree, and we have an agreement as to how we're going to communicate. And the ONC, Office of the National Coordinator, has said, this is the mechanisms we're going to use. This is the common agreement. It also addresses data. Well, there are a number of things it addresses, but the two key pieces is the idea of within TEFCA is the idea of data blocking, and it defines data blocking and says who actually can do, who does it impact, right? Who must adhere to the requirements under the data blocking rule, and it also talks about the idea of QHINs, and so it moves forward with the qualified health information networks, QHINs. And so with that, what the ONC is saying is we're going to build a number of additional networks over and above what we have now with eHealth, Care Quality, and Commonwealth. We're going to build a number of additional networks, and any entity can become a QHIN. And for example, a private company like a Health Gorilla or a Redox or No2 can become a QHIN. And so they can facilitate data exchange across nationally. The thing with the QHIN that I was unclear on, and I'm still unclear, and I think going back to the very beginnings of TEFCA, which is coming from 2017, is I had assumed early on when they talked about the QHINs that they were really talking about HIEs, and I thought the HIEs would essentially consolidate and become there would be a number of national HIEs, and that would become the QHINs. I think that has not been the case, and so what you're going to end up with, I think, is the HIEs there, And then additionally, we're building the QHIN infrastructure, and in QHIN, if you're going to participate and become a QHIN, and we're going to connect to a QHIN to exchange data, then you're going to have to agree to certain protocols. For example, FHIR was one of those, right? And there are a number of other requirements, as participating with the QHIN. We've reviewed that at Highbridge. I think today, from our perspective, in relation to TEFCA and the QHIN, we're taking a wait and see approach. And we've been contacted by a number of vendors asking us to join their QHIN. And our approach today has been, let's wait and see. Let's see, it seems like there's a lot of questions out there. Do the QHINs exist with the HIEs? What happens to the HIEs? What happens to the traffic with the HIEs? How is that all going to work together? For me, it's general lack of clarity on the idea of how HIEs are going to exist with the QHINs, and the protocols, and it's onerous. And so for now, we're taking a wait and see approach, and we'll see where the companies go with their QHINs. We'll see which ones are approved for actual to be a QHIN, and then we'll pick one. We are staying connected to that whole movement. And when we get better clarity from the federal government, from the ONC, and from these private companies as to the direction, then we intend, we'll certainly participate. But until we get some level of clarity on what it all means and how it's going to impact us, and what does it mean to our technology, that has to be changed to work with the QHINs, then we're going to take a wait and see approach.
So as we wrap this up, is there any other takeaways? Josh, do you have anything as we talk about data sharing and interoperability? Is there anything you would like to share?
Just one comment on FHIR. While, I think FHIR is, a great standard and a great protocol. And while we don't have any current, members or potential members using FHIR, we do have a very powerful interoperability platform that can certainly support various use cases for FHIR. So if we have any members out there or potential members that have use cases that may require FHIR-based transactions or queries or APIs, we'd love to chat with you about that.
Yeah, and I'd also add one other piece to that, and the Highbridge is in relation to interoperability and data exchange. Highbridge is your technology partner for this activity. We will stay current with the latest trends and directions. We will stage our system such that it prepares you all for the eventual movement in whatever direction that this ends up. We are staged well for this. We are preparing for it. It being either TEFCA or some other direction, FHIR additionally, and we'll stay current. And we'll turn to us when you have questions about this. Feel free to reach out to us. We have a whole team of folks that focus on this every day. And as we see changes or have new understandings, we'll certainly communicate that out to our community to make sure everyone can meet the requirements as they're laid out.
Thank you all so much. That kind of leads into thank you so much, Lloyd, for mentioning that. We are here to keep them current, keep them up to date, to provide them with all the changes and evolving, and like I said, all the changes that are going on with ONC and CMS. And we also offer continuing education through our program Format Approved. You can use the coupon Highbridge20 to receive a 20% discount. So there's courses around our courses recognized and recommended by physicians, MAs, practice managers, and you get certificates around HIPAA and other continuing education opportunities. We also have other learning opportunities through the Center for Leadership and Disability training opportunities, the responsive, providing healthcare and screening to individuals with disabilities, and accessible and adaptive communication. There's free continuing education provided to physician assistants and medical providers. Thank you all again for joining our webinars. every third Tuesday of each month from 12 to 1. Please sign up for our High Bridge e-newsletter. Register, receive updates. Thank you, guys.